Welcome back, coding marathoners. You've made it to part 37 of our 100-part CPC exam series, and that is just incredible dedication. Today, we're taking a massive leap right into the surgery section. We're specifically targeting the eye and ocular adnexa, so think strabismus and cataracts, along with the auditory system. Now, I'll be honest, these sections, they're absolute minefields for bundling traps on the CPC exam. But hey, by the end of this explainer, you're going to be navigating them like an absolute pro. Let's dive right in.
So, first up, I've got a question for you. Are you falling for the cataract coding trap? The AAPC exam writers absolutely love testing this specific scenario. Before we reveal the secret to dodging it, make sure to like, share, and subscribe to Decode Healthcare with Harshal so you never miss out on these exam-saving tips.
Okay, notice how directly the CPT logic maps right to human anatomy. The eye and ocular adnexa section, spanning codes 65091 to 6899, is organized directly alongside these physical structures. So, your cornea is your clear window. The lens focuses light, which, is exactly where cataracts form. The retina houses those vital photoreceptors. And your extraocular muscles and eyelids control movement and protection. Understanding this structure-to-function link, that's a real game changer. It instantly helps you isolate exactly which code family you need to be looking at in your manual.
All right, lean in for this one because this is an insider secret that will absolutely save you points. Cataract surgery coding, which spans from 66830 to 66984, really comes down to the specific technique. When a patient undergoes standard cataract extraction, like phacoemulsification, which is code 66984, the insertion of the intraocular lens, or IOL, is heavily bundled. Do not double bill it. You literally never report secondary IOL insertion, code 66983, separately during that initial extraction. Now pay super close attention to complex cataract surgery, code 66982. You only use this code if there are very specific indications. We're talking a myotic pupil requiring mechanical expansion, iris prolapse, or a strict need for zonular support. The exam is going to try to trick you by listing the IOL insertion as a separate step. Don't fall for it.
Right, so intention and anatomy dictate everything here. For glaucoma procedures, you absolutely must distinguish between initial versus subsequent surgeries on the exact same eye. With blepharoplasty, the specific reason for the eyelid surgery changes your CPT section entirely. Cosmetic? That's integumentary. Functional? That bumps you into the eye section. And while we're on the topic of eye muscles, let's talk about strabismus surgery, code 67311 through 67345. Coding this relies purely on anatomical muscle classification. Ask yourself, is it a horizontal muscle, like the medial or lateral rectus, or a vertical muscle, like the superior rectus or obliques? You also have to carefully count the exact number of muscles operated on per eye. Single? Two or more? It matters. And definitely watch out for those crucial add-on codes. If there's previous open extraocular surgery, add code 67331. If there are suture adjustments, report add-on code 67335. Always read that operative note very, very carefully.
The auditory system escaping the tube trap.
So, the crucial difference here really lies in the tube itself. A plain myringotomy is simply an incision into the eardrum, and that's coded as 69420. But if the surgeon actually places a ventilating tube, boom, you jump straight to tympanostomy. And remember, your code choice between 69433 and 69436 depends entirely on the anesthesia. Was it local or topical, or did they use general anesthesia? Oh, and absolutely do not forget to append modifier 50 if this procedure is performed bilaterally on both ears.
Beyond just ear tubes, we need to navigate the deeper auditory structures. So keep your tabs ready for mastectomy in the 69501 to 69511 range, stapedectomy, and cochlear implants, specifically code 69930. Critically, you've also got a master tympanoplasty procedures, code 69631 through 69646. These codes are highly specific. They depend on whether the repair was done with or without ossicular chain reconstruction, which is also known as osticuloplasty, and whether it was performed with or without a mastoidectomy. You've got to pinpoint those exact details in the documentation.
Now, we honestly cannot talk about ear and eye surgeries without talking about the operating microscope add-on code 69990. Here is your explicit warning. A lot of microsurgical codes already bundle microscopic visualization right into their base description. You only report this add-on code if the primary procedure does not already include it. It is absolutely crucial to always check the parenthetical notes under your primary code. If the guideline says the microscope is included, you must leave 69990 off your claim to avoid a frustrating unbundling denial. Okay, rapid fire time. Here is your one-page summary cheat sheet. Seriously, grab a screenshot of this. Just remember, cataract extraction, like 66984, always includes the IOL, and keep your eyes peeled for complex indicators like myotic pupils for 66982. Know your strabismus muscle counts. For ear tubes, tubes equal tympanostomy, not myringotomy, and definitely remember modifier 50 for bilateral tubes. Watch out for that microscope bundling with add-on 69990. And for eyelids, always verify if it's cosmetic or functional. Locking these specific rules into your memory will absolutely guarantee you points.
What an explainer. You've just conquered some of the absolute trickiest bundling traps in the entire CPC exam. But hey, the marathon continues. Next time, we're decoding radiology CPT coding. We're going to dive deep into diagnostic imaging, ultrasounds, mammography, interventional radiology, and radiation oncology. It's going to be a big one. But before we go, I want you to ask yourself this. If an operative report details a complex cataract extraction, but the surgeon completely forgets to mention the specific mechanical expansion used, are you downcoding that to a standard removal, or are you querying the provider? Think about it. Keep studying hard, and I will see you in part 38.